Hello, everybody. Thank you for joining us. Good afternoon. A couple more minutes for people to join in, and then we'll get started. Hello, hello. One more minute, and then I promise I'll get started with the presentation. All right, so thank you for being here. Good afternoon, everybody. I'm Aida Nielsen. I'm the project director, one of the project directors at the Michael and Susan Dell Center for Healthy Living at UTHealth Houston School of Public Health in Austin. My research is primarily focused on improving food access and increased intake of fruits and vegetables, so I'm thrilled to be today's moderator. Today's webinar is hosted by the Michael and Susan Dell Center for Healthy Living. The center's vision is healthy children in a healthy world, with the mission to advance health and healthy living for children and families through cutting-edge research, innovative community-based programs, and dissemination of evidence-based practices. Thank you to the Michael and Susan Dell Foundation for providing funds to the center to host today's webinar. Information about the center's work and resources can be found online. Please scan the QR code on your screen to access our health resources. The slides for and a recording of today's webinar will be archived on our website. And if you have any questions during the presentation, please enter them into your questions chat box for a Q&A session at the end of the presentation. Without further ado, I'm excited to introduce our speakers today. Firstly, Dr. Elizabeth Polinard. Dr. Polinard is a nursing professional development practitioner for perinatal services at Ascension Texas, and a clinical affiliate faculty member in women's health at Dell Medical School at UT Austin, where she conducts research and develops clinical education for healthcare providers. As co-founder of the Food is Best Medicine program and the Ascension Texas Council on Racial and Health Equity, she's committed to eliminating health disparities. A certified forest therapy guide, she spends her spare time hiking, reading, and commuting with her exceptional family and friends. Additionally, I'd like to welcome Dr. Alexandra Vandenberg, Associate Director of the Michael and Susan Dell Center for Healthy Living and Professor of Health Promotion and Behavioral Sciences at the UTHealth Houston School of Public Health in Austin. Dr. Vandenberg specializes in addressing food disparities and promoting health through environmental and policy initiatives. With over 2 decades of research and more than 120 peer-reviewed articles, her work focuses on interventions to alleviate food insecurity, improve food access, and influence obesity-related behaviors in low-income, ethnically diverse families. I will now hand it over to Dr. Polinard to begin the presentation. Thank you.
Thanks so much, Aida. And thank you all for attending, and a special thanks to the Michael and Susan Dell Center for Healthy Living for offering this opportunity to discuss what has become one of my favorite topics. The story of Food is the Best Medicine is a story of philanthropy and connection, successful community partnership, and ultimately improved health outcomes for the birthing people and their newborns in our community. Next slide, please. So a little bit of background of the Food is Best Medicine program. In 2019, when the Ascension Texas Council on Racial and Health Equity was established, one of the first things we wanted to address was food insecurity and how it was contributing to both local and national rates of severe maternal mortality and morbidity. Recently, there's been a national call to focus not just on things like postpartum hemorrhage and OB hypertension, but also on social determinants of health in an effort to mitigate the fact that the U.S. stands as the sole developed nation in which high severe maternal mortality and morbidity rates continue. Along the way, we learned that 1 in 8 Texans experience food insecurity. That equals approximately 1.4 million households. And Texas is just one of 9 states with higher food insecurity averages than the national average. Food insecurity is positively correlated with poor maternal outcomes and an increased risk of newborn readmissions. And at Ascension Seton Medical Center, Austin, the hospital where we are piloting this initiative, 50% of the birthing patients are un- or underinsured. Next slide, please. So how did we get started? The first thing we did was implement a food insecurity screening question into our EHR. It is now part of our labor and delivery admission intake. The question is, in the last 12 months, did you ever eat less than you felt you should because there wasn't enough money for food? A short while later, we were very fortunate to connect with Victoria Threadgold, who is the Director of Grants for the Ascension Foundation. I think of her as a grant wizard personally, and she was able to help secure seed funding for an initiative wherein we bought 100 $100 HEB gift cards to distribute to those people who identified as food insecure. However, we had a very expansive vision for how to address food insecurity. And part of that vision helped us secure an invitation to a program called UT Connect, in which we were connected with a grad student, Christopher Reyes. I think you'll hear his name a fair amount throughout the presentation. I consider him like the hub, basically, of the wheel of Food is the Best Medicine. And I'll tell you why. Because of our connection with him, ultimately we were connected with UTHealth Houston, the Cook's Nook, and FarmShare Austin. And through these community and academic partnerships, Food is the Best Medicine was developed and now implemented. And personally, I cannot think of better community partners. So Food is the Best Medicine, or FBM as we refer to it, is a program in which people who deliver at ASMCA and identify as food insecure may have nutritious meals and fresh produce delivered to their door once a week for 8 weeks. And this is during the critical 8-week postpartum period. Next slide, please. So we deliver nutrient-dense and culturally relevant foods, including 6 fully cooked and prepared meals and 4 veggie and grain-forward meal kits, as well as 1 produce and pantry staples box. That in itself equals 5 meals. All of these together equal 120 meals delivered over the 8-week period. Those choosing not to participate in FBM are given a $100 grocery store gift card, as well as some education on healthy eating. Next slide, please. This is an example of what is in the box. So on the top of your screen there, you'll see some meals from the Cook's Nook, and on the bottom is the produce and shelf-stable pantry box. Our first boxes were delivered on September 15th of 2023, and one of the drivers reported that as the boxes were being unloaded for one family, the woman receiving them said, "Oh my gosh, they're so big." It was very gratifying. Next slide, please. So our process is really straightforward. Again, we ask the question in labor and delivery, and if the answer is positive, then that person is referred to our amazing social work department. Our social workers follow up and then refer to our FBM program coordinator, who happens to be Chris Reyes. I hope he never graduates. He then confirms eligibility and gets people registered, and the food delivery occurs shortly thereafter. I do want to point out that the process is has been made purposefully very simple for participating families. Everything is mobile friendly and ensures 100% remote participation, so no one has to go anywhere in order to receive this food. Next slide, please. One more review of our players. At Ascension, we provide the participants and the social work help, and a fair amount of our money is donated by philanthropists through the Ascension Foundation. UTHealth Houston at Austin is responsible for program management, implementation, and evaluation. The Cook's Nook provides the wonderful nutrient-dense, healthy prepared meals as well as the meal kits, and FarmShare provides the produce and the shelf-stable pantry items. And in addition, FarmShare is our delivery mechanism. They're the ones who deliver the food to the participants. Next slide, please. Our overarching intent is to positively impact perinatal and health outcomes. We intend to do that by reaching the 4 goals you'll see there on your screen: alleviating food insecurity, promoting equitable access to nutrient-rich foods, increasing quality of diet, and then reducing the physiological, mental, and emotional stress caused by food insecurity. And I'll now hand it over to Dr. Vandenberg, who will speak more about this as well as our outcomes.
All right, next slide, please. So thank you, Elizabeth, for kind of starting the story, and I will continue where she left off. So first, my name is Sandra Vandenberg, and I am at the Michael and Susan Dell Center for Healthy Living. And before I begin, I just want to acknowledge our funding agencies, because they are the ones that have made it possible for us to actually further this project and also do the evaluation. So our funding agencies include the American Heart Association, the Danone North American Institute, and then also Austin Public Health. So again, I'm very grateful for them providing us this opportunity to enhance the original Food is Best Medicine program, and then also to conduct an evaluation. Next slide, please. So again, adding on to what Elizabeth was talking about, we now have this great program, Food is Best Medicine, which delivers 8 weeks of food to food insecure new moms. A very, very necessary program, but also, is this sustainable? What happens when when those 8 weeks of food delivery stops? What is the household? What are the moms going to do then? And so we wanted to kind of think about, what makes this more sustainable? What can we do in addition to just delivering the food? So we have 2 versions of the Food is Best Medicine program. We call these our enhanced versions. And one is called the in-person version, or FBM, in-person FBM. And in this program, we again have the original 8 weeks of food deliveries, plus a community health worker component. And this component consists of home visits and phone calls by community health workers with the intention of helping the families create a more stable and resilient financial household. And we are doing that by connecting the families with food resources and other financial resources that are already existing in the community. And then again, the idea is that once we stop, once the 8 weeks of home delivery stops, that the family now has other options, easy options, right, where they can also get food and potentially other financial support if necessary. So that is our in-person FBM program. And then we also have our virtual FBM program, which consists of a food waste platform. And the food waste platform, which was created by Cooksnook, essentially provides the same information that the community health workers do, but it's all virtual. And so women can access this platform. It's like a website, and here's a picture of kind of like the homepage to your left on the screen. And there are different buttons they can click on, looking at different recipes, looking at some nutrition, community resources, etc. So again, we've tried to make this as similar as possible to what the community health workers are providing as well. Next slide, please. So given that we now have 3 versions of the program, right? We have the original, and then we have the FBM in person and FBM virtual. We thought it'd be really great to do an evaluation of the impact and the feasibility of these 3 different versions. So again, just to remind you, the food standard, FBM standard, is the control group in our study. So again, these are the participants that are receiving the standard program. And we have 50, or will have 50 women enrolled in this group. Then another 50 women will be enrolled in the FBM in-person group. Again, this is where, in addition to the food, the women also get in-home visits and in-home calls, or in-home calls, phone calls by the community health workers. And then lastly, our 3rd group is then the virtual group, where the women get the food, and then in addition, they get access and reminder text to access this platform called Food Waste. And again, we'll have 50 women enrolled in this group. Next slide, please. So our research questions, again, focus on the impact and also the feasibility of implementing these different programs. So our 2 main research questions are the following, as you can see here on the screen. So the first one is, compared to mothers in the FBM only group, do mothers in the FBM in-person group have greater food and nutrition security, greater diet quality, higher rates of breastfeeding, and lower rates of postnatal depression? We're very interested in depression, given that we are seeing really, really high rates of postnatal depression, and it seems to be one of the predictors of morbidities in this postnatal period. Second research question is very similar, but it states, compared to mothers in the FBM only group, do mothers in the FBM virtual group have greater food and nutrition security, greater diet quality, etc.? So we're looking at the same outcomes. And I'll give you a little bit more information about these outcomes in the next slide. So these are our main outcome measures, or impact variables. And we're looking at additional variables as well, but these are the main ones. So the first one is diet quality. And this is with a focus on fruit and vegetable consumption. And we're measuring these by selected items from the 26-item NCI DSQ screener. Then we're looking at food security, which is measured with a 6-item validated USDA screener. I'm sure all of y'all are familiar with that one. We're not, and again, as most of you have done community type evaluation studies, there's a balance between what you really want to measure and best way to measure it versus what is feasible, and trying to keep the instruments as short as possible. So we didn't go with the full USDA scale, we just used the shorter one. We are also looking at nutrition security, which is measured with a 4-item scale. We are also looking at breastfeeding rates, given the importance of breastfeeding and the benefits to the infant. And these are this is measured using items from the CDC's infant feeding practices study. Then again, we're looking at postnatal depression or mental health status using the Edinburgh postnatal depression scale. We're also looking at home cooking and the frequency of home cooking, which is assessed using a 3-item validated scale. You'll see some of the items that are in these scales in just a minute when I present some of our results. And then lastly, we're looking at rationing coping strategies. And this is a 5-item scale that looks at different behaviors that people may do when they don't have enough food to eat. For example, they share meals or they skip meals and things like that. And so again, we have this self-report survey that the women complete at baseline. They completed immediately after they finished the intervention, and then 3 months later. So we are looking at some some delayed impact of our intervention. Next slide, please. So what I'd like to do is present you with some of our results. These are preliminary. We have not completed our data collection, and we're doing a rolling enrollment. Given that we are working with Cooksnook and FarmShare, who already have other clients that they also provide food to, we needed to make sure that we weren't enrolling too many people at one time. And so the decision was to do this a rolling enrollment where 4 mothers a week are enrolled. So, we have first week 4 mothers, second week at that point we have 8 mothers, third week we have 12, right? So then we capped it again to make sure that both FarmShare and Cooksnook could handle the additional meals that were being needed to be delivered and prepared. So currently we have 113 study participants. In the FBM standard group, we have 46. In the in-person group, we have 47. And in a virtual group, we have 20. We have 109 pre-tests completed. And these numbers are from like last week. So they're not completely up to date, but as up to date as possible. We have 76 post-tests completed. And I didn't mention this earlier, but we are also sending out weekly surveys via text to all the moms. And these include 5 items, and it's really just looking more at satisfaction, etc. We actually had a really hard time getting participants to complete these at the beginning. We then started offering some incentives, and now we're getting lots of surveys back. So that's great. It's giving us great information. And again, that it's processed data, but it helps us to really tweak the intervention and how we're implementing it. As of last week, we have made more than 1,020 deliveries, and I would have to say, as an intervention and implementation goes, it's been very, very smooth. I mean, we've had tiny little hiccups, but overall, given the coordination that is required for this project, it's been pretty amazing. It's been very smooth. And so I will present some of the results, like I just said. And so these are as of August 20th. But we were running analyses last week. We looked only at the participants for whom we had both the pre and the post test completed. And this is the immediate post test, not the delayed post test. So again, these are preliminary results. Next slide, please. Right, so I thought I would start by just giving you some demographic data, just to show you what our sample looks like. And for those of you in Austin who have worked with lower income families, mostly living on the east side of Austin, I mean, you will see this is very, there will not be any surprises here. So we have more than half of our sample is not greatly educated. It's either less than high school or just a high school graduate certificate. We have about 65% Hispanics, about 17% whites, and then 10% African American or Black. In terms of employment status, and remember, this is baseline, so these are moms at home, but they answered as stay-at-home parent. And then lastly, our household income question. We have over half of our sample has a household yearly income under $15,000. So these are definitely people who probably need some extra help in terms of food and again, other financial resources, of course. Next slide, please. So some more demographic data. In most of our families, we have 2 adults, although quite a few have more than 2, either 3 or 4 adults living in the household. And in terms of kids, again, mostly only 2 kids, but then we have quite a few of households that have more than 2 kids, so 3 or 4 kids. So these are large households, as you can see. And then most people live in apartments that they rent. We asked a question about if they are currently receiving WIC or SNAP or going to a food bank for food. And these numbers don't necessarily add up to 100. People were able to click more than one, but we have about 70% of the moms that are currently on WIC, but only 21 on SNAP and really very few going to a food bank. So this is where we feel that our community health workers can really help, helping people, make sure they are on WIC, make sure they're on SNAP, because I would say, the majority of our sample is eligible, but may have other barriers to enrolling in these programs. And so that's, again, one of the functions of the community health worker component is to help households enroll in these programs so that they have a more stable financial or food, at least food assistance, once our program stops. Next slide, please. So here are some, again, preliminary results for our pre and then immediate post-test. And so let's talk about breastfeeding. So, we had a pre, are you breastfeeding, and post, are you breastfeeding? So at the beginning, we had about 31%, 32% who said, yes, we are exclusively breastfeeding. And at the, 8 weeks after that, we had 30%. So most people that started exclusively breastfeeding are continuing. Now, the folks who answered they were breastfeeding and also feeding formula, we had 60%, 59% in that group. And then we had 9% who said, not breastfeeding at all. If you look at the post-test, it's very interesting to me. You see kind of like that the numbers have switched. So we only now have about 14% of moms who are breastfeeding and feeding formula, and 55% who are not breastfeeding at all. So I imagine that's the people who started, at baseline with the breastfeeding and formula, that they then converted to, not breastfeeding at all. So this is definitely an area where hopefully, even though our intervention is not immediately addressing breastfeeding, we do hope with the community health worker visits that this also can be part of that, really just promoting the health benefits of breastfeeding, both for the mom and for the infant. So if you look at the boxes underneath this question, like I mentioned earlier, we were looking at frequency of preparing breakfast, lunch, and then dinner from scratch, so home cooking. And if you look at the last lines there, 5 to 7 times, you see that we see a pretty good increase in people that are preparing meals from scratch for breakfast, for lunch, and we saw the same increases for dinner. We don't have that represented here. But it's nice to see, right, that people are increasing their home cooking. Next slide, please. We also asked some questions, just, really these are their perception, right? But when you participated in FBM, did you eat more fruits and vegetables? And we saw, 74% said, yes, we're eating more fruits and vegetables. When we asked how they would experience or rate their experience with FBM, we see almost 100% saying positive or very positive. And then I love this result, that FBM helps save you money on your weekly grocery bill, and 88% said yes. And again, this gives them then some extra money, right, to pay maybe for necessary medications or paying for rent, utilities, etc. This is, I love that particular result. And then also we asked, you know, has this changed your opinion of Seton, given that we recruited everybody at Seton? And yeah, about 71% said yes, my opinion of Seton is better. So that's a good result. That's we'll talk a little bit later about, you know, what we would like Seton to do with this program, but I think this is very positive. Then here are some results of our food frequency questions. And again, we see increases for veggies between pre and post. For whole grains, it's a significant increase. And then we see increases for fruit. Again, you know, thinking about our sample size, it's fairly small. So the fact that we're seeing increases, but they're not necessarily significant, I think is okay at this point. I hope for our final analyses, we will see some more significant results, but at least they're trending in the right direction. Next slide, please. So in terms of food security, right? I mean, this is kind of how we all started this project. Very great to notice these results. At baseline, we had about 17% of people who said they were food secure. And then when we look at post, we see about 47%, and this is a significant increase. So very happy to see these results. Then this last one is, again, looking at postnatal depression. The Edinburgh scale is a set of questions, and then there's a certain way to score these. And if a person scores 12 or over, they are likely suffering from depression. So if you look at these results at pre or baseline, you see that we have about 10 mothers who were considered, you know, or could be suffering from postnatal depression, while we have only 5 at our post test. So again, very good trends the right way. Love seeing these results. Next slide, please. So again, these are preliminary results. We are hoping to finish our recruitment for this study in a few months. We'll be analyzing the data, but in the meantime, we are you know, considering what are we going to do right after this pilot study. And we are currently working on an NIH grant, and part of that NIH grant is to extend the 8 weeks to a 4-month period where we deliver foods and then have the community health worker aspect in the food waste platform. We hope to be able to, at some point, to broaden our delivery. Right now, we are somewhat restricted to certain zip codes, although these particular zip codes make up most of East Austin, where most of the low-income folks here in Austin live. But the reason we are doing that is because FarmShare is currently the community organization that is delivering all the food, and we wanted to stay within their regular delivery zones. But at some point, you know, we're thinking about different ways. How can we expand this? And then also, how can we expand additional Ascension Seton hospitals, both locally and then nationwide? And then our very long-term goal would be to affect system change within the Ascension Seton for long-term impact. So really try to create policy around this program, and that it becomes just institutionalized, and that this is a normal way of doing things within Ascension Seton. Next slide, please. So this was the end of our presentation. We wanted to make sure that there were, you would, you know, keep enough time for questions. So I just want to point out our team here in this picture. I don't have a cursor, so I can't show you, but if you look at the right side, the woman with the red shirt, this is Victoria. She's the one really who got us started with her funding, you know, finding funding for us. Then we have Chris. We have Alicia, we have Elizabeth. Oh, Alicia is from FarmShare. Elizabeth, of course, you know. Then we have Andrea from FarmShare. We have Aida and myself. And unfortunately, who is not pictured is Joy at Cook's Nook. And we will have to Photoshop her into this picture. I think she had to leave early. This photo was from a meeting at the American Heart Association. Anyway, I will open it up for questions now. Thank you very much for your attention. And this is, like Elizabeth said, this is just such a fun project. And we have weekly meetings that started January 2023, and we still have weekly meetings. And this is always a fun meeting to go to because we love the people we work with.
That was great, Sandra. Thank you, and thank you, Dr. Polinard. That was really great. So please, reminder, feel free to type in your questions in the chat box, and we'll get to those as they're rolling in. And before I bombard you with my questions, Sandra or Elizabeth, do you guys have anything else you want to touch on?
I don't think I do. Thank you for the question, though.
I'm good.
So Sandra, you mentioned the Foodways platform, and you also mentioned that the majority of the participants are Hispanic. Is that website in Spanish as well?
Yes, yes. All our materials, from the consent form to the surveys, to the materials that community health workers may provide, to the platform, everything is both in Spanish and English. And, you know, I wish we could expand on different languages because we do have large portions of Austin, you know, with different people with a different language background. And that is something, you know, we need to look into as well so that we can serve more people and more diverse people.
Thank you. So obviously the study is still happening, but is it possible to see that website, or are you trying to wait until the study is over, then it can be disseminated widely? Because I'm assuming it's a really good resource, right? If it aggregates all resources from what's available here in Central Texas.
So we are waiting till the study's over, and it is almost over before, because you know, we're really doing a lot of analyses with the analytics, like the metrics and stuff, like how many people are accessing the website, etc. And so we kind of just want to keep it a little bit more simple at this point, so that only the women in our study can access the website or the platform. So for right now, we are keeping it private.
Got it. So then after that 3-month follow-up,
yes,
that's when it can go out. Okay, fantastic. We'll be on the lookout for that. One question that came in is because, as you mentioned, the households are quite large. It's not just mom, dad, one child. Is the amount of food that's delivered increased? Does it, you know, does everybody get the same amount, or do boxes increase like based on the household size?
Elizabeth, do you want to take that?
Sure. No, everyone gets the same amount of food. Our intention is to really serve the birthing person and the newborn subsequently, right? But we would love to be able to provide enough food to feed an entire family. At this point, our goal is to provide enough food to feed, again, the birthing person primarily.
Yeah, and can I just add to that?
Please.
Yeah, I mean, the food boxes are already quite expensive, and you know, if we want to make this a feasible, you know, a program that can be picked up by others and implemented, we can't. Although, yeah, we would love to feed the whole family, but we'd have to figure out ways to make it less expensive, because it's already about $100 a food box. And so, again, how do you create a way to make that, to increase the food in the box, but still make it, you know, feasible?
Now, speaking of food boxes, that I think another question I have is that getting tracked? Is the mom eating everything in the food box, or is that leading to like food waste, or is the mom sharing the food with her family? Are those data being tracked?
Yes, of course.
Yeah.
Yes, we are tracking that, and that is a part of the weekly survey. And the question is really, very simple questions, but what portion of the food box are you eating yourself, etc. It's worded in a better way. I can't think of the exact question right now, but
So
yes,
with
we are
all the
tracking that.
surveys that women are asked to take, are they getting any incentives?
Yes. So for the pre, post, and delayed post surveys, women are getting gift cards, $50 gift cards. And then for completing, if they complete 5 out of the 7 weekly surveys, they receive another $20 gift card.
And Aida, if I could interject, anecdotally, we've also received feedback from participants that have indicated that they are definitely food sharing too.
Oh, yeah.
We've heard things such as, without this program, there would have been days my family would not have had food. So we feel confident there's food sharing going on.
On one part, I'm very happy to hear that, but part of me just goes, oh man, what happens after that 8 weeks, right?
Exactly. Yeah.
So is there talk with Ascension about expanding the program, putting them in more hospitals? Can you touch on that, Elizabeth, or is that
Sure. I can. The short answer is that right now there is a growing awareness of our program. The program was just featured in a national Ascension report that went out to the entire national network. And that so far has been, I feel like there'll be a snowball effect. Right now, it's a matter of increasing awareness. And we're hoping that, and of course, we're getting nothing but positive feedback and support from Ascension leadership. And so we're hoping to build on that, especially as our outcome data continues to roll in and reflect some really robust outcomes.
not to put all the funding onus on like Ascension, is the goal later to have like health insurance pay for this? Are you guys advocating for that? Are you like knocking on congressmen people's doors?
I think that's in our future. Right now, remember, we've basically we're almost a year out with our launch, and we've continued throughout the year to expand the program in various ways, right? And so I definitely think that's in the future for us, future vision.
Great. Should our attendees help with that? And
Yes. Because we can't,
We would never turn
lobby.
down
lobby away, people.
offers for help.
All right, let me give you a break, Elizabeth. Sandra, what are some challenges that you've seen with the study so far, and how have those been overcome? And what advice do you have to anybody else who's wanting to try something similar?
Challenges. So, and I'm looking mostly from the evaluation side, right? Just like I said earlier, I mean, I feel this has run very smoothly. We have at some point, some of the food boxes have gone to a wrong house, and that has mostly been due because at some point, so FarmShare is the group that is delivering, but they also use DoorDash, and sometimes they're just, either we're not getting the correct address from the participant themselves, or DoorDash there's been some mix-ups. So we've had a few boxes delivered to the wrong person, and we're just hoping that wrong person is hopefully eating all the food, so there's no food waste. But I feel overall that has not been a huge issue. In terms of data collection, I feel we're doing really well. Again, comparing it to other studies that I've been involved in, and probably because we do have quite a bit of contact with the participants throughout, it hasn't been that difficult to collect the post-test data or even the 3-month post-test data. Of course, Chris may tell you something different, or Aida, you may know something different. But I feel that, again, compared to other studies, it's been pretty smooth.
question.
Think what other challenges? I really can't think of any.
It's a great study. No challenges at all. Perfect.
That's right.
Everybody can email you and get the scoop. I said, I'm sorry if I missed this, but as someone who works in a hospital, I see a lot of intake questions and chart information missing. How are you ensuring the food insecurity question is being asked to applicable patients?
That's a really good question. Initially we thought we were going to just right out of the gate have maxed out on enrollment, and that didn't happen. And so we those of us at Ascension kind of went back to the drawing board and made sure that we educated staff about the program. Our social workers helped with that as well. And so though we are not doing chart audits, I think an indicator for us is that every week now we're definitely at our max in terms of enrollment. And that to me indicates that the question is being asked and answered, and the people are getting the referrals that they need.
And the level of depression reduces, Sandra. Do you think this is a result of the nutrition or more relate to the general program that includes improving the security and handling of the food?
That's a good question, and I am not an expert in mental health, but I would assume it's a combination, right? It is the nutrition from the food, but it's also having less stress, at least for an 8-week period, right? I mean, for those of you who have been new moms, it's a very stressful period, and I can't imagine to have that additional stress of not knowing where your food is going to come from, not knowing if you can feed your family. So having some relief in that, I would imagine that would, reduce stress. So that would be my answer, but I would like to see what Elizabeth has to say about that.
Oh, I really don't have anything to add. I think that kind of connection and relief, right? Mental and emotional relief of stress like that is very important. And I would guess that that is the primary driver of the result that we've seen.
Quite a few questions around the cost. Are you tracking cost of the entire project? The resources, the staff time, all of that, and what is the cost of the delivery? And this program, because there's so many boxes getting prepared and delivered, it can get expensive. So what are your plans for scaling it up? Is it just that NIH grant that hopefully gets funded, or?
So we are tracking costs. AHA, so the American Heart Association, is really interested in that. And it is, this is something that we need to really sit down and think about. Like I mentioned earlier, a food box currently costs about $100, it may be a little bit less than that right now, but that is all those meals, the meal kits, produce, staples, and then also the delivery. But it's still $100, right? So yeah, I mean the NIH grant, that is not going to be the the end all. I mean, that will be another study, because if we see that, so my personally, I'm really interested in seeing, the community health worker component is also expensive, right? It's home visits, and that takes up people's time, people's resources, and costs, versus the platform, which is, now that it's been developed, kind of free, right? So if we see results that are just the same from both of those groups, well, then maybe the virtual platform is a better way to go because it's more feasible and less costly to implement. But you still have the food cost, not negating that. Victoria, again, who works at Ascension Foundation, has been amazing at getting money. And I don't know how many funding agencies we now have just for the food costs. I think we probably have about 6 or 7 or 8. And these are smaller grants, but again, every small grant helps to be able to buy more food. So I think for now, and Elizabeth, you may have more specifics, but I think we have enough money to deliver food until next year, 2025, probably September, around there. And so Victoria, I know, has been instrumental just in trying to, grant writing and getting more money. But again, that maybe is not the solution either. I mean, at some point, it would be great if insurance would pay for this, and it would be a very smart thing to do, I would imagine, right? It's prevention. So yeah, I don't know if I answered your question at all, but those are just kind of some thoughts that I have.
Yeah, I mean, public health gets funded so much here, but it will happen. Are the participants in the program located in food deserts? Are there supermarkets located within a few miles from their living places?
In general, so again, this is general. The folks that we are serving are in East Austin, and some of those areas are considered food deserts. I don't know if all of them, qualify for the official definition of a food desert, but as those of you in Austin know, I mean, East Austin has very few grocery stores, and even if there are grocery stores, the quality may be lacking. So, that's my answer.
And could I just add one thing? I think that one of the things that also makes our program, for me, it's such an offering, is that we don't have to worry about transportation, or our participants don't have to worry about transportation and getting to a grocery store, at least for the meals and the amount of food that we deliver.
Yeah, and just adding to that, and again, this specific population, new moms, I think it's super important, right? Not to have carry your child possibly on the bus, right, to get to a grocery store or things like that. So the transportation issue is, I think, even a bigger issue with this specific population.
And time, I would imagine, saves lots of time, not to have to come up with a list, go get the things, make the things, all the stuff. Does the program include some healthy nutrition education? Thinking long-term, how can the family sustain beyond the 8 weeks?
I think that's sort of a twofold answer, right, Sandra? Like, I can speak to, I mean, they do get some actual paper education, right? There's a flyer that's basically a nutrition, a one-pager on nutrition, but then at least those who are connected to the community health workers, as well as the Foodways program, there's lots of education involved with both of those aspects of the study.
Yeah, and really, I think what we're finding is people do know what it means to eat healthy, and they know what they should be eating. It's just, again, the access to healthy food is more difficult, and also, again, given that we're working with a large Hispanic population, we want to make sure that people know how to prepare the foods, the staple foods and the produce that they're receiving. We are trying to make it as specific to the different cultures as possible, but we're also using locally grown foods, right, and organic foods. So participants may be receiving something that they may not have used before, but we try to have the recipes that will go with the produce in the boxes, etc. And then again, the Foodways platform does have, again, also recipes, little videos, etc. So there is nutrition education going on, but more of recipes and not even necessarily food preparation, because I think most people, I mean, they know how to cook. It's just cook with these specific ingredients.
The recipes are Spanish and English.
Yes.
Yes.
Has there been any, going back to the funding, has there been any looking into involving SNAP funding or other USDA funding?
The answer is no, not at this point. Though I will say that Ascension here locally has another food access program that's being funded with a USDA grant.
And
so it's
I
possible.
actually just had a conversation with someone this morning who made me think, you know, maybe SNAP Ed maybe could possibly be part of this. I don't know. But so currently, no, the answer is no, but it's definitely something that we need to look at further.
And have you explored partnership with the local food bank to create a more sustainable solution? And to piggyback of that, there was another question about, Sandra, how you share the results and not many people go to a food bank. Do you connect people to those resources? So sort of two questions.
Yeah, so the last question, yes, for sure. And then again, that's part both of the food waste platform and the community health workers. I mean, they really talk to the household like these are resources within your community, right, that are already available. So yes, for sure. And then the first question, collaborating with the food bank. We've had some conversations. I know the food bank here in Central Texas Food Bank is also doing a really cool project where they also are delivering food to people's households, not necessarily the same population, but they are doing some of the same things we are doing. So it would be great to collaborate with that group. Obviously, they have access to lots of food. And we actually are having a little Food is Medicine mini summit coming up where we are pulling together everyone in Central Texas who is doing some kind of food as medicine work and trying to see, you know, where are the common places where we could collaborate instead of everybody working in their silos. Because I do feel there's several really great programs going on right now, but we're all doing it kind of on our own. You know, what could happen if we all just collaborated? And I would imagine there would be so much synergy. And, you know, we all want the same thing ultimately, right? Is to improve the health of the people that we serve. So if anybody's interested in that mini summit, let Aida know. We can send you an invite. It will be on the 13th, September 13th.
13th of September.
Yeah.
You said yes, connecting people to the food banks, the community health workers are doing that, the food waste platform. What about that third group, the, you know, the control, the one who's just getting 8 weeks of boxes?
We are, as far as I know, we currently are not doing that. I'm trying to think because we do have information that goes into the food boxes. I'm sorry, I don't know the answer. Chris would be the one to ask.
Yeah, I don't know that either. I do know that before these participants are even discharged, though, from ASMCA, they get a lot of information about community resources. So that's just reinforced by the community health workers and foodways. And the control group then at minimum is going to get that resource teaching from social workers while they're still an inpatient.
We have a question about, is the study working directly with local farms and farmers to provide the food boxes?
So we're working directly with FarmShare. And if you're not familiar with FarmShare, they do grow their own produce on I can't remember how many acres they have. It's an awesome farm. It's organic, and so we are, but we are working exclusively with them for right now. Just, you know, they were the founding member kind of this program, and so yeah, so yes and no, I guess. Yes, we're working with FarmShare, but no, we're not working with any other farmers at this point in time.
You also mentioned participants' lack of formal education. Have you found literacy in their own language to be an issue? We have about a minute.
Yes, I know.
I know because the surveys and everything is done at a lower reading level.
Yes, yes.
Okay.
We've tried all our materials, the website, everything at a very low literacy level. There may still be issues, and the community health workers have been instrumental in helping people like complete like baseline surveys and stuff. But so again, that's only the group that is getting the community health worker component. The other groups, well, I do know that they have been able to call, and Chris or some of our other grad students have helped them with completing some of those questions.
Well, thank you both. our presenters, and thank you all very much for joining our webinar. Please remember the recording, slides, and resources mentioned will be posted on our site along with upcoming webinars. Thank you. Bye-bye.
Thank you.
Bye.
Bye-bye.